better?
Please.
No, I will give it. Encore une minute et on y va. We start. Encore faudrait-il pouvoir. Hein? Ça marche pas? Ça marche?
Oui, je pense que oui.
Pour moi? Donc, je n'ai pas besoin d'appuyer sur le bouton, vous réglez tout? Parfait. Merci beaucoup. Excellency, ladies and gentlemen, it is a great pleasure to give you a warm welcome in a fresh room, which is better, I think, also for the activities of our brains. We are here with two sponsors, and you will hear their representative, Ambassador Lauber, and Deputy Head of the Health and AIDS Division of the Netherlands Ministry of Foreign Affairs. I will give them the floor to Ambassador Jürg Lauber and to Mr. Vice-Citoyen. But first of all, I want to tell you that the other sponsor of this event, or the main organizer, is the Global Commission on Drug Policy. The Global Commission on Drug Policy was created 11 years ago. You can see on the publication, you can take here that it is a group of, of self-committed citizens of the world who had the privilege to have high responsibilities in their country as a head of states or head of governments, but also to have a large influence as economic leaders and cultural personalities worldwide. This group has decided to devote time, energy, to advocate for changes in drug policy on the basis of the negative and positive experience they had gathered before. Positive in the sense there are responses that help to avoid the harms caused by drug in society, and negative because they failed, perhaps following the traditional prohibitionist policy to solve or to help to progress for the well-being of their population. So it was this mix of experience that brought together people from all continents. And our work is really to follow 4 pathways to reform drug policy. Pathway 1 is to put health as the absolute priority, which means develop new kind of treatments, develop and give access to harm reduction measures, is to develop new kind of harm reduction, and we need them in front of the changes also in the drug markets. Secondly, and that has also to do with health and is very important, is give access to all to medicine that have this double aspect, to be recognized as essential medicine. Mainly, I would say, for an example, morphine for the treatment of pain. But in the meantime, are substances under the control of the drug control system, which has huge consequences, and we will have the opportunity to speak about that, about the lack of access of these medicine for a large majority of the people of the world. Third, we are advocating for decriminalizing in all aspects, not only criminal, but also not only penal, criminal, but also administrative, all punishment for people who use drugs. And using drugs means also possessing drugs or producing drugs for their own consumption. Well, decriminalization has also to do with health, because as long as the people are criminalized, their access to health services they need, even health services perhaps aimed directly to their problem of dependency or addiction, will be very, very difficult. But there are other reasons why we are advocating for decriminalization, and there are reasons of fundamental human rights, like the right of privacy and the like, or the necessity for the state not to pursue activities that are not harming others than the person itself who take a risk taking or having some activities. Fourth pathway is in the criminal justice. You have to focus not on the people at the bottom of the criminal pyramid, but at the summit. I mean, you know all the presence of black market in the streets of our cities, and you know that if you arrest one person in this street, the day after or some minutes after, he will be replaced by somebody else. They are really the precarious proletariats, if I can say so, prolets of this pyramid. And they are not those who know the whole chain, who know who is responsible, and you cannot hope that arresting these people, criminalizing them in a disproportionate way will help to solve the problem. But attacking the summit is another story. It is a story of corruption, it is a story of money laundering, it is a story of multinational enterprise that can move from one country to the other and be well protected also by violence and by the possibility to evade the prosecution. So put emphasis on this, collaborate internationally for this aim, and refrain from harsh punishment for the people at the bottom. Now, these 4 priorities of our Commission are not in contradiction with the framework of international conventions, even if the interpretation of this convention has often brought governments to very harsh punishment, inclusive for consumers. Harsh punishment for people with little quantities in the hand of a substance, with even death penalty in certain countries. The interpretation, the current and long-standing interpretation of the convention has also brought to the persecution really of all communities designed as being those who are responsible for the consumption and the trade for illicit substances. But as I stressed just before, states can change that. Being respective of the convention, they can renounce to punish consumers. They can focus their repression. They must bring the controlled medicine to the people, and so on. So we have a fifth proposal. And the fifth proposal is regulate the market of the drugs. Take them from criminal hands. Put the states in responsibility. And as you know, this issue has become in the last year more timely in discussion about one substance, which is cannabis, and with countries saying we will make experiment about how regulation could be organized and what it could bring to the solution of the problem of consumption and production of cannabis in our countries. And this is a new evolution that took place in the last less than 10 years. But this is also a problem of compliance with the convention, and this is another issue we will have to discuss together at this table and with you. We, as a Global Commission for Drug Policy, and I would say of reasonable people who had experience of responsibilities and out of a sense of responsibility, we say abolish prohibition. These substances are like other psychoactive substances to be regulated by the states. And I would say to be regulated in a way taking account the harms, the possible harms that come from these substances. They might be very different. I mean, chocolate is not very, very regulated. I speak as a Swiss, huh? But it is a little bit regulated. I know, for instance, palm oil and such things are a problem. It was not accepted as a regulation by the EU, and Switzerland had this regulation and had to abandon it because of our common market with the EU. But just to give an example, heroin is another psychoactive substance. In Switzerland, we prescribe it by doctors, and we deliver it in day clinic. Or better said, we gave them in day clinic until the COVID came. And with the COVID and with the people, the consumer coming in age, we are now giving it at home, and we will soon give it in nursery, how do you call institution for elderly people? Because they will not be longer able to come to the place, to the day clinic. So there is a huge range of regulation, and we as a Commission think that it is our duty to study more and to bring on the table different models of regulation and to advocate for implementation of this. But we are also advocating, and we have to do it, for a fundamental change of the conventions, because, as I said, regulation is not in the convention, it is beyond, so that we want really to solve the problem, we have to attack, if I can say so, deep reform of the international system. And we will speak about that here all together this afternoon. So it is my honor now to introduce Ambassador Jürg Lauber, head of the mission of Switzerland at the UN in Geneva. And I must say, Jürg Lauber is active here, also in this field with his staff, but he was also in New York, and he has followed the whole discussion on reforming drug policy from New York to Geneva. Jürg, you have the floor, and thank you.
Thank you very much. It is certainly my honor. Thank you. Good afternoon, Excellencies, distinguished members of the Commission, dear colleagues. I'm really honored and certainly pleased to take the floor at such an important event this afternoon. And I want to thank the members of the Commission on drug policy for bringing us all together here in this room, and I understand from all over the world for people who follow us virtually. I was asked to share the outcomes of the recent, what was called the Brandenburg Forum Geneva with you. So before we hear more about the report from the Global Commission and before the distinguished panelists discuss the possibilities for enhanced coordination for drug policy reforms, I will try to explain briefly the framework and to summarize the main findings of the Brandenburg Forum. Switzerland co-organized that event at the beginning of June with Germany, the Netherlands, Norway, the Transnational Institute, and the International Drug Policy Consortium. This second Brandenburg Forum Geneva, held under the name Aligning Drug Policies with Human Rights, convened a broad and diverse range of states, human rights experts, and civil society representatives. I would especially like to mention, of course, the participation of our former President and Minister of the Interior, Ruth Dreyfus, who was there in her capacity, obviously, as a member of the Global Commission. Colleagues, over the last 15 years, a growing number of bodies within the UN human rights system have paid increasing attention to the human rights consequences and dimensions of drug policies. In Switzerland, we have adopted what we think as a pragmatic, comprehensive, and evidence-based approach to drugs over the past decades. Switzerland developed a four-pillar approach based on prevention, therapy, harm reduction, and repression. The reason why I'm underlining this is that according to our national experience, it is not only an ethical imperative and a legal obligation to comply with human rights in drug policy, but it is also more successful. It produces much better results. Hence, we are pleased to see that milestones such as the 2015 and 2018 Human Rights Council resolutions or the latest report on drug policies by the UN Working Group on Arbitrary Detention have become important contributions to drug policy making at both UN and national level. The Brandenburg Forum took stock of such progress and offered space for discussions on what should be the next steps in our efforts to better align drug policies with human rights. Let me mention three proposals that were discussed at the forum. First, strategies to mobilize member states around a new Human Rights Council resolution on human rights and drug policies. There may, of course, be other means to keep the issue on the agenda of the Council, such as joint statements and side events as the one bringing us together today. However, in order to ensure the continued engagement of the High Commissioner's Office and of states, a new resolution was the option that received most support at the forum. A second proposal referred to initiatives to increase the capacity and the interest of treaty bodies and special procedures mandates. In fact, several treaty bodies, special rapporteurs, and working groups have started to include the topic into their work. There is, however, potential to strengthen this trend. And finally, an important point of discussion at the forum evolved around opportunities to bring the human rights dimension of drug policies to the UN bodies in Vienna, thus increasing system coherence. I can imagine we will hear more about this point in the panels later today. A report summarizing the debates of the forum and the conclusions of the second Brandenburg Forum Geneva will be published in a few weeks. Excellencies, dear colleagues, the challenges ahead obviously remain huge, but we will continue in our common aspiration to live in a world where states design and implement drug policies in accordance with their human rights obligations. Thank you very much.
Thank you so much for the Deputy Head of the Health and AIDS Division from the Netherlands Foreign Office. Thank you. You are jumping in to replace one of your colleagues.
Yes.
Thank you.
Thank you very much, colleagues and excellencies, ladies and gentlemen. I have to apologize for our ambassador at large for gender equality and women's rights. She was supposed to be here, but she fell ill. But I'm happy to speak on her behalf to you. And let me start by really thanking the Global Commission to gather us here today and bring us all here together. As I mentioned before, I was posted in Vienna for the past 4 years, and I think we really always try to advocate to bring Geneva and Vienna a bit closer, because we do need, law enforcement, we need health, we need human rights. So I'm very happy that this provides a space now to continue doing so. And let me emphasize on behalf of the Netherlands why it's such an important meeting we have now on drug policy reform and why we believe it's very urgent. Because despite the progress we have made over the past decades, and in particular since the UNGAS 2016 meeting, this discussion is more needed than it was in a long time. Because COVID, the COVID pandemic has, as with most diseases and crises, disproportionately affected women, girls, and marginalized groups. Criminalization and drug policies that are not aligned with human rights have discriminatory effects, discriminatory outcomes, and amplify these effects on marginalized groups that are already in vulnerable situations, including people who use drugs. This is unacceptable, it's preventable, and it's contradicting with all the evidence available. We are particularly concerned with the health and rights of women who use drugs. We collectively have to stand in front of them and around them to reduce the harm of their drug use. Therefore, drug policies that put health and well-being at the center are urgently needed, and this includes harm reduction services. This is possible, I think it was stated already, within the existing drug policy architecture, including the 3 conventions. I think it's very important for us to underline. The UNGAS outcome document, the 2030 Agenda for Sustainable Development, and the UN System Common Position all guide towards more humane drug policies. These are also key principles of our national drug policy that focus on health, human rights, and development, and the need for evidence-based and balanced approaches. And while we build on our strong commitment to these 3 international drug conventions, the need for reforms is urgent. It is essential, we feel, to remove the barriers that are preventing people who use drugs to access essential services, including harm reduction services. It's equally important to protect and promote the human rights and people who use drugs by treating them with dignity and by providing equal access to health and social services. We need to ensure that people who use drugs have access to justice and legal services, and policing measures should not prevent people from accessing harm reduction and health services. It's important, like we do together here, to bring together law enforcement, health, and the communities of people who use drugs. We need a common understanding and solution. And what's very important for us as the Netherlands, we need to learn from each other. We need to be frank about what we try, we need to be open about what works and what doesn't work, and talk about it without being behind dogmas or year-old agreements. We have to talk and learn. And 1 year ago, during the high-level meeting on HIV/AIDS, countries recommitted to end AIDS as a public health threat by 2030. And people who use drugs are at the highest risk of HIV/AIDS infections. And women who use drugs are particularly vulnerable to stigma, discrimination, gender-based violence, and criminalization. And these are serious barriers that hamper people to access life-saving treatments. Drug policies need to put people at the center. That's why the Netherlands in our HIV/AIDS policies and programs are prioritizing marginalized communities. We support the Love Alliance partnership that brings together key population movements in 10 African countries, and we empower them to speak. And that's also something that's very important. We need to empower them to speak, those people who we make policies around to speak up and to have a seat at the table. We cannot talk about them without involving them. They need to discuss their realities. And we think that the joint UN program on HIV/AIDS, UNAIDS, is playing an important role in this, and so is UNODC. We value the work of UNODC very, very much, and we do find it's very important to continue a dialogue between the WHO, UNAIDS, and all the other UN actors in Geneva and Vienna. And I hope that this discussion today will contribute to building these bridges. Thank you very much.
Thank you so much. May I begin with asking Louise Arbour some question about the system? I mean, we couldn't find a better analyst of the framework of the International Convention and in relation with human rights than the former High Commissioner for Human Rights and judge and professor. So, Louise, there were progress in the last year, in the last decade, about challenging the strong interpretation of the convention, of making silo thinking about the Vienna Convention. It was a great effort to progress towards a more holistic approach. I mean, you can we can cite quote the special session in 16 of the General Assembly on drug problems, the position taken by the agency of the UN under the leadership of the General Secretary called the Common Position Paper on Drug-Related Matters. We can cite also collaboration like the International Guidelines of Human Rights, Drug Policy, some common work between WHO and the UNODC. But all this was just the beginning of a process of thinking about the real rationale of the convention. Can you tell us how far this rationale is put really in question?
Thank you. Excellencies, that's the way it always starts when we have a UN gathering. Ladies and gentlemen, I'm not sure if I'm going to be immediately responsive, Ruth, to the question you've put to me, because I think if we're going to talk about a case for reform, we need to take a step back. And I should say at the outset, I speak very much in my now free personal capacity. I'm no longer an office holder of any kind, so I don't speak on anybody's behalf. But I'd like to take a step back and reflect on why exactly the need for reform, and I think this will illuminate the kinds of reforms that we need to contemplate. First of all, speaking for myself, I consider the so-called war on drugs the greatest moral pandemic of the 20th century. It's hard to think of any other global policy that has mobilized the entire international community that was essentially rooted, I think, in a kind of moral panic, certainly not in any kind of science. And if it had any kind of scientific underpinning, it has been proven, I think by any measure, to have been one of the greatest kind of public policy, international public policy failures. There are more people today who use drugs. The drugs are cheaper today than they were 60 years ago. They are considerably more potent, and they're a lot cheaper. So whatever the objective of a drug-free world, I think anybody would have to recognize that the framework that was put in place has proven completely inadequate. So there are two possible issues. Just make it tougher, and constantly there's some who argue for that. If we just put a little more money in law enforcement, we would get there. Again, I would say after 60 years, the burden would be on those advocating this kind of approach to suggest that it could have the completely reverse effect. I think all it would do is more of the same. More consumers, cheaper drugs, and of course, the benefit of vast amounts of money going to illegal networks. So I think it's important to have that context in mind, that this was the ambition, this was the original plan, and the need for reform, I think, is very much based on the failure of that plan. The second aspect, if we put ourselves back 60 years ago, I think it was based on a model of the drug supply chain that was very much a kind of north-south model that we no longer believe is appropriate in the managing of international affairs. Essentially, it was based on a dichotomy between supply and demand. And I think the view was that demand was very much in the richer North countries. Certainly those driving the movement were of that way. The demand was there. And the supply was certainly in the North American context from the South. Because countries had no real capacity to control the demand, they decided to try to control the supply. And in doing so, they inflicted unconscionable harm, and I think President Santos will talk about that, through their efforts of controlling the supply. And even in their efforts to control the demand by threats, not only threats, but the use of imprisonment for personal consumption of minor drugs, they also inflicted more harm through this repressive model than the drug consumption themselves. Not that they are completely harmless, but the harm that comes from repression is considerably larger, which brings me to the first, I think, attempt at reversing this model, which was the so-called harm reduction strategies. And I find that certainly the early advocates of these strategies, I think, were very clever, because it suggests that these were initiatives, and you know what they are, safe injection sites, syringe exchange programs, particularly in prison, supply of fresh, uncontaminated syringes, and so on. All these initiatives appeared to be, to address the harm caused by consumption. But in fact, what they were really addressing is the harm caused by repression. None of that would have been necessary if the consumption would have been in a public health environment in which there would be no shame in obtaining the product for self-protection for the millions of what I would call recreational drug users in the world today. The vast majority of them are, by any measure, quote, unproblematic drug users. They are not criminals. They don't suffer from a form of addiction that becomes problematic. And left to their own device, they would have been able to employ self-protection measures that would have rendered that. So the harm, there is in part harm of consumption, but it comes from repression. The harm comes from consumption of poorly identified products, tainted, hair or products that are tainted with fentanyl. So you don't know what you're buying, you don't know what you're consuming. All of that is related not to the product itself, but to the prohibition model that vastly increases the harm. So these harm reduction strategies, I think, were the very, very first attempt to put a crack in that wall, that tight wall of prohibition that was the international framework, duplicated in different countries with different levels of severity or enthusiasm, ranging from some form of mild tolerance of simple possession and consumption of relatively mild products to, at the other extreme, the death penalty. So the levels of enforcement vary. So harm reduction strategies, I think, were the first attempt to take on the system. Certainly in my country have been extremely effective. And I have to say, in large part, through the intervention of the courts. A well-established safe consumption site in the city of Vancouver had the support of the local population, of the mayor of Vancouver, of the police chief, of all law enforcement agencies, but it was blocked by a federal government, which at that time was adamant in maintaining this, in my view, moral panic-based public policy. The matter was taken to courts, and it's the courts, the Supreme Court of Canada, using, again, all aspects, human rights-based approach, public health approach, that ordered the government to permit that to take place. I think after the beginning of these harm reduction strategies, we've seen at the national level something the Commission has been recommending for a long time, which is decriminalization of possession for personal use. The first steps in that direction, as Ruth mentioned before, were, in a sense, I don't want to say easy, but easy enough, particularly since they were not a frontal attack on the international law framework. And I'll come back to the international law framework, but the Narcotics Convention leave enough space for the decriminalization of possession for personal use that it was possible for states to take that step. And that was certainly the case in Canada. And I have to say, in 2018, the full decriminalization of cannabis was the non-event of the year and continues to be the non-event of the century. After there had been a few voices predicting the apocalypse, carnage on the roads of the nation, that everybody would be completely out of mind consuming legal drugs and would all kill each other. Needless to say, none of that happened. I don't have the latest figure, but the trend certainly is that the legal market now is slowly gaining over the illegal market. It wouldn't happen overnight, that's pretty obvious. People had their suppliers. But the variety of products, good quality products, very well identified in terms of proportion of different substances. It's not all a happy story. I think a lot of people lost money in engaging in these ventures. They thought this would be a new way of doing business, and some of them, I think, were surprised by the result. But be that as it may, it's well established, certainly in Quebec, which is the province where I'm from. The market is actually regulated by, it's at the provincial level, and cannabis products are sold by the state, just as alcohol is. So not only did we go to decriminalization, but quite a longer distance. I suggest to you that this is inevitable. You cannot decriminalize drug possession and drug use and turn a blind eye to the supply side. Where is it going to come from? In fact, this was a problem with these safe injection sites because there was an environment in which drug consumers could come, but they had to come with their own product, which they had to acquire illegally. This is not sustainable, I think, as a model. It was pretty clear that the minute you engage in decriminalization, it calls to move into regulation. You need to regulate the source of supply, the mode of transmission, the taxation, if there is going to be such thing. So these experiments with decriminalization have now opened the door to, in my view, the necessity for regulation. It could take many, many, many forms, but it's inevitable. And this is where the international framework is very problematic. As much as it's possible to navigate the international legal framework with decriminalization, no. the state to become a supplier of a controlled or prohibited substance, it's pretty difficult to maintain the position that you're still in compliance with your international obligations. But I pause here because the problem we see with compliance with the international sort of narcotics control environment is actually the international law has an internal conflict between the narcotics control framework and the human rights framework. For instance, in international human rights law, the death penalty is not prohibited at large, but it is only permissible for the most serious offenses, of which drug trafficking is not one. So you cannot be in compliance with both. You cannot be in compliance. So if you engage in regulation, in my opinion, you've made a choice to be in full compliance with international human rights law, but very unfortunately, it may put you in non-compliance with some of the specifics of the international drug control framework. This is where we are today. And I should add to that that this is very unfortunate because in so many respects, international norms are aspirational. It's very true in the human rights framework. It's true in the Refugee Convention. It's true of many areas in which we've set an ambitious goals for mankind, you know, kind of very aspirational pathways. In this particular environment, unfortunately, I think we've done the opposite. Whatever might have been the rationale 60 years ago, as we stand today, I think we have an international law framework in the field of drug control that is, in fact, an impediment rather than a force for progress in the matter of dealing with drug consumption. So this brings us to what should be done about it. Well, I think some countries will just try to find a legal argument to rationalize their non-compliance with the Narcotics Convention. So there are various legal techniques through which you could do that. My own sense is that all of these techniques, inter se or denounce the convention and rejoin with reserves, and there are all kinds of technicalities, not all that interesting really. What's interesting is sort of thinking about what should be done. And it seems to me that in the international environment, the principle of universality is really important. It's very important to try to bring everybody under the tent. If we start advocating for countries to walk away from international treaty that they don't like and create little groups of non-compliers, well, I may be happy with that in this environment, but what about other environments in which I wouldn't want people to step out and form their non-compliance club? So I think that what's incumbent on us, and I think that's where the Commission is we just have to face the reality. It was hard to call for decriminalization for personal use, but it's inevitable after that to call for state regulation, and therefore it's inevitable to start seriously talking, as long as it will take, for a complete revamping of the international treaty framework for narcotics. There are millions of small steps that are useful in that way. So activities in the Human Rights Council and with treaty bodies and special rapporteurs, a further engagement in the health sector. And I think that's another way to look at it. I think for the longest time, certainly our take was we need to move from a law enforcement model to a public health model. Great. Now I think we've taken another step and say, and now we need to move also from a just public health to a human rights model. And we haven't even touched the economics of it. There are lots of angles. It's just, so I think we need to approach it, I would call it, under the umbrella of a kind of public interest model that will bring all the strands together: public health concerns, human rights concerns, economic concerns, essentially the well-being of all. So as I said, I think we're at the stage now where we need to face the reality that it is time to start the conversation, these are long-range projects about a complete revamping and reconfiguring of the international narcotics drug control system. But in the meantime, I think the conversations that are taking place, the meetings, the debates, the discussions are all very useful. There are a couple of steps that we are advocating that I think in an incremental way will move that in the right direction, which is in particular to take some parts that are clearly public health parts into WHO. I think that what's called the scheduling, the classification of drugs, which of course is a losing battle because every time one is proscribed, a new one appears on the market. So it's like, what's the game in English? It's called whack-a-mole. Boom, and the mole comes up through the next hole. Well, it's a little bit that kind of game in the area of synthetic drugs, which is the expanding market. So I think this whole question of scheduling, a definition of drugs, like for instance, you know, the usual example, why is cannabis prescribed under the Narcotics Convention, while the level of harm coming from tobacco and alcohol is vastly superior, demonstrably so. So I think drug classification, scheduling should be in WHO, and so should be access to medicine. So, sorry, small steps, but big picture. Sorry, I'm finished.
Thank you.
I'll come back.
Yeah, you will come back. Thank you so much. You spoke about the programmatic aspect of many of the fundamental treaties in the community of nations. I mean, when you look back to the 60s, you see that the dream was a drug-free society. And this is an illusion. And we are still under the impression of this illusion in most, I would say in most national legislation and in the discussion we have in Vienna. Even if the necessity to consider that it is an illusion is obvious, but the political consequences to this is still lacking. But Louise, you began speaking about the harm and the failure of the policy. I would like to ask the former president of Colombia, Juan Manuel Santos, to speak about what this means concretely in a country that paid perhaps the most heavy price for the failure of this policy. And this from a person who went from a warrior to a Peace Nobel Prize winner in the same country. The same man has experienced both roles. Juan Manuel, please, you have the word.
Thank you very much, Ruth, and thank you all for inviting me to this panel. I would like to start with an anecdote that I read a couple of years ago in a recent biography of Winston Churchill, written by a historian called Andrew Roberts. Andrew Roberts, in his book, says that Churchill, during Prohibition, took a train in your country, Louise, in Canada, and went all the way from Montreal to California. And he arrived exhausted in California and asked for what he really liked, a drink. And they said, "No, Mr. Churchill, I'm sorry, this is prohibited here." So with his usual sense of humor, he said, "What a strange and bizarre country this is," referring to the United States. These incredible profits that are made out of the sale of liquor, you give them to the mafias. We, in my country, we give it to the treasury. That encapsulates what this problem is all about prohibition. And if Churchill would be reborn and came to Geneva to this meeting, he would say, what a strange world this is. They have some conventions that what they do is strengthen the mafias, damage the people, damage society, and what is the object of these conventions? And as Louise was saying, yes, when they were negotiated, many people thought that they could have a drug-free world. But if you go to the indigenous communities, like in Ecuador, for example, or in Colombia, or in Africa, they would say that the consumption of drugs is as old as history. To have a drug-free planet is impossible. What is possible is to make that consumption the least harmful possible. The lesser evil among the evils is doing away with prohibition instead of prohibiting. And we have experienced that in Colombia. Colombia is probably the country in this war on drugs declared 60 years ago that has suffered the most of any country in the world. And we have done everything by the book. And I've done everything by the book as Minister of Defense, as President. And we are still the #1 supplier of cocaine to world markets. After losing our best leaders, our best judges, our best policemen, our best journalists, and a lot of blood. So I, like Ruth was saying, from being a warrior by the book against the drug trafficking, I changed my mind to become a more practical warrior against the collateral bad consequences of prohibition. And I am absolutely convinced today, that's why I am honored to be part of this commission, that I think that having studied, having lived, having been a victim of this problem, there is no other solution than to do away with prohibition. And the problem is, okay, how do you do it, and what approach should you take? And that's where I think what Ruth said and what Louise said and what is in the documents, an approach from the human rights point of view is the correct approach, which will slowly but surely create the sufficient momentum to change the conventions, to change the statu quo, which today, unfortunately, in the majority of the countries, is still in the wrong side, in the side of prohibition. Even my country, we started progressing and a government was elected that took some steps backward. I think that the new government, which was elected yesterday, will again take the steps in the right direction. And we are now, this building is called La Maison de la Paix, the House of Peace. I will make a parallel with peace, with the peace process. When I approached the peace process from the human rights point of view, the rights of the victims, which are the rights of the victims, the rights to justice, the rights to reparations, the right to the truth, the right to non-repetition. With that approach, we found a way to legitimize a transition, and we applied something called transitional justice, where I know for many people it's difficult, but it's a necessary step to take the perpetrators of victims perpetrators of crimes against humanity, war crimes, and give them a special treatment in order to have peace. Well, I have been suffering from the opposition to that scheme for many years. Every peace process has that type of reaction. Some people, peace in the long run is where you draw the line between peace and justice. How much justice are you willing to sacrifice in order to have peace? No matter where you draw the line, there will always be some people who claim more justice and people who claim more peace. Well, in the war on drugs, you find something similar with a difference. We were talking with Ruth this morning. Peace is an ideal that everybody should dream of and should fight for. The consumption of drugs is not peace. It's an evil. But then how do you make that the lesser evil? By doing away, after all the experience we have with prohibition. And you have to convince people. Any public policy to work has to have some ingredients. One of them, very important, is that people should understand why this public policy has been adopted. It's almost a rule of thumb that if you have a policy that people don't understand, they will reject it. And the second rule of thumb for a good public policy is policies that take into account the people who are going to be affected by this policy. You cannot impose that. Always, it's much better to include the people. In this case would be the drug addicts and other people who are victims of this malady, to be part of the solution, of the policy. So approach, a human rights approach, like the Commission has been trying to promote in the last 10 years, of course with the health component, but I would say that right now we have reached a point where we have enough evidence. We don't have to invent more arguments. Now we have to convince people that evidence is true and that a change is necessary. That takes time and takes a lot of perseverance. And that's why I think what we have to do now is to multiply the message and have people understand that this is the only solution to a problem that is increasing. I come from a region, now not Colombia, Latin America, and the same can be said with Africa, that the problem of drugs, of the drug trafficking is increasing, that the power of the mafias that control is increasing. And you probably read about an incident some days ago. A prosecutor general of Paraguay, which is in the south of South America, the extreme south, he went on his honeymoon to the north of North America, to Colombia, to a beautiful place that I recommend you to go, called Cartagena. And he was with his wife in the beaches of Cartagena, and some people in a jet ski came from the sea and assassinated him. That is a proof, that was in the last 2-3 weeks, that the mafias have become much more powerful, that in many regions of South America, of Latin America, because Mexico and Central America are worse off, in Africa, and some areas in the United States and in Europe, the state has been displaced by these mafias. And so this is a very fundamental problem that, going back to Churchill, could be corrected if you do away with prohibition. So this is our big challenge, to convince people that, and I understand Louise's position of not wanting countries or group of countries to separate from the conventions, because that would create a bad precedent for other issues. I mean, are you going to not obey the law? And she is right. That's why we have to keep pressing UNODC and the United Nations and the countries that, for usually political reasons, they oppose any change in the regulation. Because this is an issue that is very easy to manipulate politically. To take the hardline prohibitionist stand is popular always. You have to be very patient and be like a teacher, like a professor, in order to take the other stand, and that in politics sometimes is costly. I paid the cost 10 years ago. In the Summit of the Americas. The president was not Biden, that he held a summit just a week before, last week. I held it in Cartagena 10 years ago. President Biden was there. I made a speech proposing, for the first time of a sitting president, the legalization of drugs. You cannot imagine the reaction, of course, promoted by my opposition all around the country. I went to anywhere and they said, "You are going to poison the children of Colombia. Why are you doing that, Mr. President?" And I had to start making meetings with the mothers and asking them, "You have a son, you have a daughter?" "Yes." "If she's caught with drugs, would you like her to go to jail or go to an institution to help them for their addiction?" "Oh, go to the institution to help her with the addiction." "Well, that's exactly what I'm proposing." "Oh, Mr. President, why did you not explain that before?" That is the type of challenge that we have. But I think we have been progressing. And we need to persevere, we need to keep the momentum, because it's the only way out.
Thank you so much. Well, it's a great lecture you gave us on the need for politicians, but also for lawyers, to help the politician to overcome contradictions and to find balance also between the needs of the, let's say, of justice and the need of regulating a society and protecting the people. So this is, I think, something that I lived also as a minister here in Switzerland. I mean, when I had to explain to the people that opening a safe injection room was in contradiction with the convention. At that time, we had to fight to make it recognized as a harm reduction measure with the time, but that saving life was a higher obligation that I had to pursue. Now, I am absolutely grateful for two persons to sit at this table. Absolutely grateful because it is their profession to live in this framework. We have here a representative of WNODC, WHO, Dr. Dilkushi Poovendran. She is in charge with one of the points where we are exactly seeing consequences of the convention on the access of essential medicine. One of these contradictions between having a prohibition on one side and the need of access on the other side. It's clear, Madame Sàenz will tell us, and she is right, that medical and scientific use of substances is foreseen in the convention. But the consequences that national authorities take from this is not to give access to these substances for different fears. And I would like first to give you the floor, because I think there is now a consensus between the international community that this is really something to be solved. There is no reason that people suffer, and it is a majority of the world's population, suffer avoidable pain, cancer, operation, palliative, so the situation of dying and so on. But the reality is another one. So please, WHO has a very important role to play, UNODC also. So first of all, I would like to give you the floor, and thank you for being here.
Thank you, Madam Dreyfus, and to all the commissioners for inviting me to represent WHO today. WHO is the specialized agency of the UN to work on public health issues, and it's mandated by the International Drug Control Conventions to make scientific recommendations to the UN Commission on Narcotic Drugs, the UN's drug policy-making body, which is based in Vienna, on the international control that should be placed upon psychoactive substances to prevent diversion, misuse, and abuse of psychoactive substances, whilst also protecting access to psychoactive substances that have medical and scientific uses. So this WHO convenes on an annual basis the Expert Committee on Drug Dependence, which is a multidisciplinary group of scientific experts that represent in their independent scientific capacity as scientists. We have scientists who represent disciplines in pharmacology, toxicology, psychiatry. I think from a scientific point of view, drug policy is multidisciplinary, and therefore one of the key aspects of convening a group of experts to make recommendations on international drug policy is that it will also be multidisciplinary in the way that the evidence is assessed. And another key component of WHO's mandate within the drug control conventions is the scientific expertise that experts that are brought into WHO to advise on drug policy matters are not representing a government, they're not representing commercial interests, they're representing themselves as scientists in assessing scientific evidence to determine whether a particular drug is causing harms to public health, whether it's causing abuse, dependence, and other harms to public health, including overdose, poisons, calls to poison control centers, and so on. And also to be independent in their assessment of the therapeutic use of a substance, to really look at the efficacy of substances as medicines. So the WHO, through the Expert Committee on Drug Dependence, makes recommendations to the Commission on Narcotic Drugs, which is, as I mentioned, it's based in Vienna. It's a group of 53 UN member states that will vote on the recommendations. They might consider to vote on the recommendations made by WHO. And the Commission on Narcotic Drugs, they view the WHO as the recommendations made by WHO as being determinative in medical and scientific matters, but the CND might decide to vote to reject WHO recommendations based on economic, legal, administrative, and other matters, which might cause them to reject a recommendation that's been made by WHO on health and scientific grounds. So in this regard, the ECDD has made recommendations on numerous substances in the past decade. There's been a dramatic rise in the number of novel synthetic drugs that have been on the illicit marketplace. These include synthetic opioids like fentanyl analogs, cathinones, synthetic benzodiazepines that have entered into the marketplace and have been associated with deaths with overdose. Often these are drugs that are kind of clandestinely manufactured in laboratories, and they might be sold as kind of falsified medicines or as other substances, which result in people taking them unknowingly, taking and consuming really potent substances. So the ECDD has made recommendations for control of those substances in the past decade or so, and most of the recommendations on new psychoactive substances have been accepted by the Commission on Narcotic Drugs, and acceptance of the WHO recommendations places a minimum level of national control that is according to the International Drug Control Conventions, and those that minimal level of control and adherence to the conventions is overseen by the UN Office of Drugs and Crime and the International Narcotics Control Board. So essentially, WHO makes a scientific recommendation into a policy-making body, which is then overseen by INCB and UNODC. One of the challenges for WHO, as was mentioned before, is the access to controlled medicines in particular. WHO holds a key role in ensuring that medicines that have psychoactive properties are accessible, and there are many reasons for barriers to accessing medicines, but also it's key to note that drugs are in many cases medicines. Fentanyl and morphine are two drugs that are considered to be essential by WHO for the treatment of pain and for the management of palliative care. Drugs like methadone and buprenorphine are considered essential for the management of drug dependence disorders. Benzodiazepines and barbiturates are needed for the treatment of neurological disorders and mental health conditions. And so these are some examples of substances that have psychoactive properties, but also have important therapeutic uses, which WHO seeks to protect in its recommendations on the international control of substances, while also making sure that the recommendations prevent or minimize the diversion, misuse, and harms to health caused by any medicine that has psychoactive properties. And part of this exercise that WHO undertakes each year is it's a very rigorous scientific process that includes both the scientific expertise of the committee itself, but also a massive global data collection exercise in which we reach out to all UN member states to gather information about specifically the health effects caused by drugs, so anything relating to the health of drugs. But actually, data on health relating to drugs is quite limited. Countries often collect seizure data, and they can have information about drug trafficking, but they might not have information about a specific substance and the health effects that are associated with it. For example, if people are presenting to accident and emergency rooms for overdose, they might not be able to have the capacity to detect that a substance was present in a person's body, and therefore they might not be able to report it to WHO. So one of the key areas that WHO works on is really improving our data collection exercise by reaching out to member states and specifically to engage with focal points from ministries of health. Often we don't always work with health professionals in the world of drugs. And so this is one area that we work on, is really engaging with ministries of health and health-related focal points to improve our data collection, to understand what substances are out there and what their effects are. And even in terms of the quality of data, one of the challenges is that oftentimes substances, people will use them together in combination. So it's really hard for the ECDD, which has a mandate within the International Drug Control Conventions, to look at specific substances, whereas some countries have enacted kind of generic legislative measures where they can place an entire class of, for example, synthetic opioids under international control. WHO can only, under the International Drug Control Conventions, can look at specific substances. So instead of looking at a class of 100 synthetic opioids that have been associated with overdose deaths, WHO has the mandate to look at individual substances that have demonstrated harms to health. So in this regard, the number of substances that the ECDD can review are limited each year based on the limited access to data, the limited the quality of the data that we receive, and also just the fact that there are many more new synthetic drugs that are being detected on an annual basis that can be actually reviewed by the ECDD. And so international cooperation and collaboration on issues pertaining to drugs is really important, that international, regional, and national initiatives working in cooperation with each other. WHO will continue to meet to convene the ECDD. We're convening the committee in October this year, and also are improving our systems, scientific mechanisms for prioritizing substances. So in terms of determining what substances are the most persistent, prevalent, and causing the greatest harms to public health. And also developing a surveillance system. So if there's not enough data to justify scheduling of a substance, to ensure that substances are being monitored at a global level. In terms of the issue of balanced access to medicines, just to underscore that WHO does work kind of in line with the 2016 UNGAS resolution to really work on from a public health and human rights point of view, and ensuring that balanced access in terms of ensuring that there is access to controlled medicines while preventing the diversion and misuse of substances with psychoactive properties. I think in terms of work on WHO, in terms of access to controlled medicines, WHO convenes every 2 years the Committee on the Model List of Essential Medicines to determine from a scientific point of view what substances are kind of essential to health systems for them to be delivering universal health coverage. And also WHO is in the middle of preparing a guideline for national policies to guide countries on how to ensure access to medicines while also ensuring safe use of medicines. And that guideline covers 7 different domains, including things like pricing and procurement, which is a notable barrier to accessing controlled medicines, issues on education, on national policies on the implementation of the drug control conventions. So currently we're undertaking a systematic review to really understand what are the barriers and what are the solutions to overcoming those barriers so that we can work towards ensuring that there is access to controlled medicines across the board, because it continues to be a problem, and there is low access to medicines, especially like morphine, for pain and palliative care, and that continues to be a priority area. Along with programs at WHO, including on harm reduction measures and mental health treatment. So
thank you so much. Yes, you see how important the work of WHO is, but the question is, from our point of view, if it is enough powerful in regard with the other actors of the system, if I can say so. I mean, for instance, in the scheduling process, the recommendation of the WHO is from this independent body and should be evidence-based, but the final decision will be a political one taken by consensus in Vienna, and some of the recommendation will be changed. Other threats were also there that it might be decided in Vienna that very important, for instance, anesthetic could be under control with consequences on the battlefield and the poor countries. So in our view, there is the necessity of a new balance of competence between Geneva and Vienna, and the need of bridges between Vienna and Geneva. A first bridge is built by Madame Sàenz because she was sent from, she's a responsible member of UNODC. She is now here, located in WHO, to represent also in this body the policy of UNODC and bring a little bit closer the two institutions. So thank you so much for accepting our invitation. And the question is, how could we reinforce really the collaboration of UNODC, not only with the Geneva centered organization, your partner, if I can say so, WHO, High Commissioner for Human Rights, UNAIDS, and others. How is it possible to enlarge this collaboration, as we heard, with UN entities responsible in development, in UNDP, in family, women, children affairs, and many others. So you have the floor, and thank you for joining us.
Thank you very much, Excellencies, public, and dear panelists. It's an honor for me to be here, and I'm very glad with the invitation. Just to clarify, Madame Dreyfus, or give a little bit more information, I am UNODC liaison officer in Geneva in the context of a joint program that we have with the World Health Organization on treatment of drug use disorders since 2009. In addition to that, I want to complement what my colleague Dr. Poovendran has said. We also have a joint program on access to controlled substances with WHO back since 2016 that aims at precisely increasing access to controlled substances for medical and scientific purposes. So, Madame Dreyfus, in terms of collaboration and including other UN agencies, I think that the role of UNODC, and I want to go back to 2009 with the political declaration and the decision to have health and people at the center and a more balanced approach between supply and demand, because since then UNODC has been working, even though I always say with the disbelief of many, but we have been really working to put people at the center and to have human rights at the center of the decisions of UNODC in its role as supporter of member states in the implementation of the conventions, but also providing technical assistance to member states to respect human rights, as to ensure that people are at the center. As you all know, in 2016, we had the special session of the General Assembly on drugs and the outcome paper, which was endorsed by the 193 member states, calling for the support to the existing drug control system and calling UNODC and WHO to strengthen collaboration. And precisely in the framework of those recommendations of the UNCAS outcome document is precisely that the UNODC and WHO signed a memorandum of understanding to strengthen collaboration in key areas: drug prevention, treatment, access to controlled substances, also the work on new psychoactive substances, working on HIV prevention in vulnerable groups, including people in prisons and people who inject drugs, and preventing violence prevention. And is precisely also in the framework of the MOU that then the liaison officer position is created to expand, to enhance that collaboration in all those 5 areas. But then, of course, I think it would not be good not to mention the UN Common Position paper on drugs endorsed by the Chief Executive Board in 2018, and the fact that since 2019, UNODC has been leading the process of disseminating the UN Common Position on drug policies that calls for a human rights, evidence-based approach to drug policy. So in that sense, the establishment of the tax team and the leading role of UNODC has been key to guide common approaches between UN agencies when it comes to supporting countries to develop drug policies, to inspire common interagency work. Is not easy. It's not easy to work with other UN agencies. We all have our own mandates, our own clusters, and I will tell you later about an interagency technical working group that has been established as part of my work. We try to support, the testing has also been instrumental in supporting that the fact that the inclusion of drug-related matters into the activities and technical assistance support that other UN agencies provide, and to try to convey one UN voice when it comes to talking about human rights and evidence-based policies. The work of the task team in disseminating, in promoting the UN Common Position Paper on drugs has, of course, focused on the work of the country teams, working with the resident coordinators in each country. And it starts, of course, with a country common assessment, making sure that all the different agencies of the UN system understand what are the key issues related to drug policy, to provide policy advice, and to include drug-related matters in their technical assistance work. In terms of concrete actions of the task team and the UN country teams, of course, supporting countries in developing legislative frameworks, in creating the institutional capacity. We believe that the capacity of countries, of the institutions at the national level, especially when we talk about the health system, for example, being really responsive to the needs of the people with drug use disorders or people who use drugs, are far from, despite the years that we have. I have devoted half of my life to working and bringing together ministries of justice, of interiors, and ministries of health to understand what it means to have a health approach. But then you go to ministries of health and there is nothing for drug use, and you go to ministries of justice and everything is guided by a law enforcement and criminal justice vision that is not conducive to the actual respect to human rights. So in that sense, it is very important, in addition to the institutional capacity, I think my colleague also mentioned the issue of data collection. Most countries develop drug policies, strategies, programs, projects based on information that is not complete, that is not reliable, that is not detailed, that to the point that allows systems that are really responsive to the needs of the people, especially the most vulnerable groups like women, children, LGBTQI communities, etc. So influencing government plans is another work that the task team has been doing, and mainstreaming human rights into drugs policies. But of course, one of them, I think Ambassador Jürg mentioned the Brandenburg, the Geneva Second Brandenburg Forum, where one of the calls was for the task team to enhance its work. I think I heard at the day funding is an important issue. For example, one of the things that I heard at the Brandenburg Forum is that out of all the UNODC budget, only 5% goes to health. And I can assure you, panelists and dear public, that of that 5% of UNODC's budget that goes to health, 95% goes to harm reduction. But we still have a strong opposition and difficulties to openly implement what is our mandate as UNODC, as UNAIDS co-sponsor, So human rights is at the core of UNODC's mandate. Since 2012, we produced a position paper on human rights across the mandate of UNODC to make sure that human rights were included in everything, from the programmatic, from the strategy development, from the program implementation, monitoring and evaluation of our programs, to ensure that the standards of human rights are reflected in all the interventions. So working with law enforcement to ensure what Ms. Dreyfus was mentioning, that the police are not chasing drug users when they are seeking treatment, that not only is limited, but is inaccessible and sometimes unavailable. Working with prosecutors to make them understand that drug use should not be penalized, but there should be administrative or non-custodial or other forms of measures different to imprisonment that is only leading to overcrowding and to violations of human rights. And also working with prisons to ensure that people who use drugs or have a drug use disorders receive an equivalent treatment to their drug use disorders when they're in prison as much as in the community. Working with non-discriminatory approaches, especially for vulnerable groups. and minorities, the rights of women. You know that women, whilst 1 in 3 people who use drugs is a woman, only 1 in 5 who are in treatment is a woman. And this is even worse for pregnant women, who are 3 times discriminated and stigmatized when they are drug users and are pregnant. And of course, just to finish, we have been doing work for years in trying to promote drug prevention, working and understanding what are the socio-cultural and economic factors that create the vulnerabilities for children who start using drugs. I think it was Ms. Arbour who mentioned something very true. Of almost 300 million people that use drugs in the world, only roughly 36, 37 million develop a drug use or have a drug use problem, are in need of treatment. So the majority of people who use drugs is only 1 in 10 that will eventually require. The problem is we don't know who's that one. So drug prevention, working with families, working with communities, working with the schools, doing selective and even selective prevention could be measures that would allow us to identify who are those most at risk that of developing a drug use when they are initiating drug use or increasing their drug use. Treatment of drug use disorders, as I said, I have devoted my life together with WHO. We develop international standards for treatment of drug use disorders, promoting evidence-based interventions for treatment. Unfortunately, and President Santos in Latin America, we have a big problem with that. Drug treatment is usually delegated or outsourced by many countries precisely because of the lack of will of including or inserting, embedding drug treatment into the health system. So these third parties, sometimes religious groups, ex-drug users groups, sometimes all sorts of organizations, and there are big scandals. I invite everybody to read about the sober homes task forces in the US. Big scandals because what is called treatment is not really treatment in the majority of countries. And we have been advocating together with WHO, developing international standards, developing quality assurance mechanisms and tools that allows to go into the treatment centers to really witness what is happening in there in terms of therapeutic approaches. Because even though science is telling, and we know exactly which are the 5, 6, 7 psychosocial and pharmacological interventions that have scientific proof that are effective, yet we still see rampant violation of human rights in the name of treatment. People being, sorry, I'm not counting my time, Madam Director, so please tell me. So,
you will be landing soon.
Okay, okay. So yes, of course, I was joking with Ms. Dreyfus when I came in, because as UNODC, I'm very happy that this meeting happened during the grill session, the season, sorry, in Geneva, because usually as UNODC, we tend to be grilled, cooked, and roasted, because for some countries, we are allowing drug use, we are too flexible, we're doing harm reduction, we're bringing syringes and needles. And for other countries, we are prohibitionists, we are a tool, we are enforcing. So we are really in the middle of a drug control system that we serve, but we don't decide. It's the member states. Exactly. You said it very well. It's a consensus system, and our role as UNODC is to serve the role of secretariat. I think that in closing, sorry, Mr. Dreyfus, I want to say that sometimes changing policy and seeing those changes that we want in the policies might take a lot of time, like President Santos says. But I invite everybody to look at maybe specific cases, like in Vietnam, we have been working for many, many years. They had, as you know, by 2015, in Vietnam, there were more than 70,000 compulsory treatment centers. I have been accompanying Vietnam to change practices. Maybe the policies are not there yet, as advanced as the Global Commission 5 pillars, but we can tell you they have introduced pharmacological treatment for opioid use disorders. They have included buprenorphine for some of the patients that cannot take methadone. And because of COVID, they even started doing take-home methadone, which is something that in a country like Vietnam, 10 years ago, we would have said this will never happen. We recently received a call from Malawi to support them in the development of their drug policy. So I believe President Santos, you said it very well. It's going to take time. We need to talk to the right institutions and the right people. But one last call I want to make: we need to have the system that will care for these people.
Thank you, Madam Chairman. You are right. The elephant in the room is less the UNODC than the CND and the conventions themselves, and the understanding or the blockade in the CND to review the convention where it is necessary, and to break also with 60 years of a very prohibitive and repressive interpretation. I mean, there is a spirit around this convention that is really fueled by 60 years of, what did you call, Louise, the panic of the 60s, the moral panic that was at the origin also of the main disposition, the hardcore, I would say, of the convention. And this is the reason why we think that many of the difficulties you have both explained from your day-by-day activities is to find there, and to find in the lack of priorities, in the lack of resources. On both sides, I would say clearly, probably also some lack of architecture inside the organization, which who is responsible for what, and so on, so that there is a practical difficulty, and there is a spirit of prohibition that is like a veil on this. But thank you so much for being here and able to respond also to the questions. I am looking on my watch. If we want to have the possibility to have a Q&A, I would ask you, Jennifer, to be not too long. We have half an hour. And you have to go.
Unfortunately, I'm very sorry, but
thank you so much.
I have a plane to catch, but thank you.
So we invited you as an academic. We invited you as, I would say, an academic who has really put emphasis on drug policy, on repressive policy also, detention conditions, and so on. You have also links with the community of experts in drug issue, like the group here in the French-speaking part of Switzerland to study addictions issues. So the floor is now yours. We ask you to tell us where we stand, looking at some progress and some perhaps backlash also. Jennifer, you have the floor.
Thank you very much, Madame Dreyfus, and thank you to the Global Commission and partners for giving me the opportunity to be here today. It's a big task to speak after such distinguished speakers, but I'll do my best. And it's also a big subject of what are challenges and success stories, so I've chosen 3 countries that I'll briefly address. So if one looks at Southeast Asia, which is often synonymous with repressive and law enforcement-based policies, and indeed like 8 out of the 35 countries that still have the death penalty for drug offenses are in the region, and there are lots of problems with overcrowding of prisons and so forth. There's one good example there recently where in 2019, Thailand became the first country in the region to legalize the medical use of cannabis. So proving that things can happen still within otherwise rather repressive context. But that's more the exception than the rule. So if we go deeper and look into what's happening in Cambodia, for example, that I know well, because it's a country where I've lived for a few years and looked at drug detention centers there, recent reports in the last 10 years from Human Rights Watch or Amnesty International, or even from the UN Office of the High Commissioner for Human Rights, have shown that the government still runs so-called treatment and rehabilitation centers, which unfortunately are nothing other than compulsory drug detention centers with human rights violations of all kinds being rife, and no access to harm reduction services or other treatment. So that's the reality. And so in terms of legal or drug policy reform, there are a number of challenges. On a slightly more positive side, the government has also been collaborating with the UN Office of Drugs and Crime to train health personnel for the community-based treatment services. There are lots of, I think there are over 400 or 430 or so different of these kinds of centers around the country in Cambodia, but they're still under-resourced and hardly any equipment. So the training still needs to be strengthened, and yeah, there's much more work to be done there for the right to health of people who use drugs to be really respected. In 2019, Cambodia accepted one of the proposals, recommendations from Portugal at the Universal Periodic Review to decriminalize drug use and put in place more harm reduction services. So that's something positive as well. But of course, then the question is, how is that going to translate into legal reform? And there are lots of obstacles and hurdles to still overcome. Just one last point about Cambodia. I think it's really interesting to look at the question of ministerial responsibility, because the centers that I just mentioned are run by the Ministry of Interior, the Ministry of Social Affairs, the Ministry of Justice, but none by the Ministry of Health. So I think that's an area where more work can be done in terms of strengthening inter-ministerial collaboration. So coming to my second example is from Africa. I think it's really important to highlight a positive development that's happened in recent years. In March 2020, the Parliament of Ghana passed the Narcotics Control Commission Bill, and it officially it decriminalized drug use for personal use, and importantly, it really shows that and treats drug use and dependence as a health issue. And so that's a major positive reform in terms of where we're going towards health and human rights based policies. So to be clear, drug use has not been legalized. It just means that instead of sending people who use drugs for personal use to prison for 10 years, their fines are applied and alternatives to incarceration explored. So supply, production, and trafficking are still offenses, but it's more this change in attitude and more looking at it from a health perspective, and then, as I said, applying fines instead of imprisonment. And significantly, in terms of what has been said today by WHO and by UNODC and also by Commissioner Arbour, is that the law provides for the implementation of harm reduction services. So that's a major win, if one wants, from a health perspective, and a human rights one as well, in terms of providing services that people who use drugs may need. And Ghana, I think, is an interesting example, too, of the engagement between civil society and government. And that's something, too, that I think is important when we look at ways to encourage more drug policy reform. So it will be interesting to see how the changes that have happened in Ghana may pave the way for other countries in the sub-region and beyond to do the same. So my third example, I was around cannabis regulation and pilot trials and so forth. I mean, Commissioner Arbour has already talked about Canada and is the expert, so I'm not going to go there. And then I have Switzerland sitting right next to so, but I will say a few words about Switzerland because we're here in Geneva. So cannabis has been considered an illicit substance in Switzerland since 1951. But very recently, or in the last few years, Switzerland has now adopted a legal framework to provide for pilot trials for the regulation of cannabis for adult recreational use. And if we step back for a moment, also since 2013, in fact, there have been administrative fines applicable for cannabis offences, and the Swiss Federal Tribunal in 2017 confirmed this when it relied on Article 19b of the Federal Act on Narcotics and Psychoactive Substances, and it confirmed that under 10 grams of possession of cannabis is not to be punishable really under criminal law. So we're in this situation where, in fact, the possession of drugs is still an offense, but technically, but with these minimal quantities, then it doesn't have to be necessarily criminally punishable. And then more recently, in September 2020, the Swiss Parliament passed the amendment of the Federal Act on Narcotics and Psychoactive Substances precisely to allow for these different trials for cannabis regulation, and it's this Article 8A, which provides this legal basis for conducting these trials. I think the amendment is meant to apply for 10 years, and during this time, the different trials that are in place are meant to lay the basis then for possible future regulation, so that lessons learned can be really implemented when it's time to regulate. So it'll be interesting to see how that plays out. And then I think it's interesting from a governance and structural point of view how, because the whole question came up from the city of Bern, asking the Federal Office of Public Health to look into the question of cannabis studies and trials and possible regulation. And that's something specific to Switzerland, of course, with the subsidiarity principle that's enshrined in the Constitution, and how the different levels, I was talking about Cambodia earlier with the different ministries being responsible, but how in this country too, from the cantons and the federal levels, how that works. So to sum up, I'm trying to be very brief because it's not easy on all of these countries, but I think this point really to reiterate around the engagement of different actors, bringing in from the local, and that's something that's done often in Switzerland, from the local, municipal, local, cantonal, and then federal, but also in other countries that way, but also then with other actors from civil society or community networks, and very importantly, and it must be said, people who use drugs and who are affected most deeply by the drug policies in place, to bring them in from the bottom up as much as possible. The question of, we've seen some examples now of positive, encouraging law reform examples, but there's still a lot to be done, as I didn't want to dwell on it, but unfortunately the number of repressive policies is still in place, so that needs to change. And finally, it was mentioned by a colleague from UNODC that it takes time, and that's for sure. So, there are moments when maybe things come together and it's time to act, so not to miss that window of opportunity. So I think science and the actors I mentioned need to be ready so that more human rights and health-based policies can be put in place. Thank you.
Thank you, Jennifer. Thank you. We have a quarter of an hour, if I am right. Oh, why? Not 10 minutes, 15 minutes. What is that, Ramon? For question and answer. It is clear that if at this table somebody, you would have something very important to say, we will try to summarize at the end or to give you the floor. But the most important, I think, is to give the audience the possibility to choose among all this information which should be really deepened and treated in a more broad and in-depth manner. So there is, I think, a micro somewhere, and there is Ivy who will bring the micro. So who is beginning?
Thank you. My name is Andres Liscano. Thank you for all the presentations. And my question is about a topic that you haven't addressed, which is the use of drugs that has not been proven effectively, but rather research on therapeutic use. Switzerland, for example, has been pioneering this in terms of, and has been one of the few countries that has allowed research projects on therapeutic use of LSD, for example, in treatment of anxiety and depression. And I was wondering what the Commission's or the other organization's position towards this is, and what recommendations you have regarding this topic. Thank you.
Well, I can perhaps answer in the name of the Commission, even if we have not realized until now a position paper after our internal discussion. But I can say that it is clear from the principle of the Convention, even if it is not applied in reality, but for our absolute interpretation that the scientific use of substances must be allowed. And it is a matter of the control of the ethic of trial, of the feasibility of trial, of the seriousness of those who make the trial to give the authorization. But the limitation that came for psychedelic was absolutely an example, a school example of the influence of the Convention on the blockade of scientific progress. And it was really the case because the psychedelic were linked with flower people, with rebels in the US against the Vietnam War. It was so clear that this group was considered as a threat for society. So the consumption they made was a threat for the morale of the whole society, so they had to be banned. And I mean, a country who is a host of the invention of LSD, it's absolutely clear. I mean, Hoffman is an inventor. It's absolutely clear that we have lost years and years of studies to know for which kind of pain or which kind of disease these might be interesting. And now we know and we learn, let's say, I don't know if we know at this stage, but we have to learn that for post-traumatic symptoms, for depression, and many other conditions, what the trials are now beginning to show is that might be we have renounced for, what would I say, 30 years to develop answers to pain, to people suffering from pain.
If I could just add, I think that's often the point of entry. I think if you look at the decriminalization of cannabis, for instance, the first step was medical use, then recreational use, right? It always seems like a step too far to talk about recreational use, or let's just call it very generically, non-medical use. But the first point of entry in challenging the tight prohibition is often through a scientific or medical use, which is permitted. The other example, I think in Canada, I forget the name of it, the chemical compound in magic mushrooms has just been accepted by Health Canada for palliative care and end-of-life ending suffering for selected patients. That's usually the point of entry, the same way it was for the use of cannabis for medical or therapeutic purposes. But I think it's an example of this entire scheme, you know, to link drugs and crime as the point of entry. It's to have the tail wag the dog. The crime aspect is the narrow, as in every other human activity, the criminal aspects, not the dominant one. You know, it's very clear that drug use, non-medical drug use in the world is neither criminal nor actually problematic for the millions, but it's the tail that's wagging the entire dog. In the same way, I was a bit surprised to be reminded that the Committee of Experts in WHO, it's called the Committee of Experts on drug dependence. Dependence. What dependence? It's about drug use, some of which creates dependency. But everything in the system has been contaminated by an ideology that focuses, I think, on the wrong. And language is not innocent, right? It just carries this assumption that the minute you see the word drug, you're into dependency or other forms of evil, when in fact you completely obscure either the completely neutral or otherwise very beneficial aspect.
If I may add something, I think that you said the example of the war on drugs and the impact that it had. And I think that the result of that research will also create the opinion matrix that will be supportive for people also accepting that these are medications. Because for many years, people are psychedelics. But science is saying that there might be, well, in fact, this is what the conventions are about, is substances that can be used, that have a medical and scientific use, and should be used whenever they...
Yes, but the big issue in the middle is not the terrible ill effects, dependency, and so on, nor the medical use, it's the recreational use. This is why people take their gin and tonic, and they say, ooh, I'll take my little medicine. Well, it's not a medicine, neither is sugar or tobacco. It's, for a lot of people, these are life-enhancing substances that they use and sometimes abuse. A lot of them not very good for their health, but this is all in the realm of personal autonomy and choice and lifestyles.
Thank you. Now we have 6 or 7 minutes left, so I will take perhaps 2 questions here, at least 2. And there is one behind, Eric, if you don't mind. And we have a reception. The good news is that we have
can
a
medicate
reception.
ourselves.
So upstairs. So all the question you cannot raise now because we cannot go too long in this frontal position. You will be able to ask them during the repression. So please, Madam.
Thank you very much. Good afternoon. My name is Veronica Espinosa. I'm from Ecuador. I was thinking about, and I think we can all agree from all of your brilliant expositions, that the toll that the world has paid for the name of this so-called war against drugs is very high. And the cost and the price in terms of human rights violation and bloodshed and even economical toll has been mainly paid by the South and the low and middle income countries in the South. So I was wondering, what is your opinion regarding the responsibility of the representatives of the conventions and the organizations that have in their mandate the follow-up of these conventions, and also states that support the conventions and that force, I don't want to say force, but highly advocate for the compliance of the conventions by the world. And also WHO and other United Nations organizations in the follow-up of the implementation of the convention and the cost they have, probably this side effect, or let's call it collateral damage of the implementation of the conventions, especially in low and middle income countries. Just to mention one single example, the access to morphine in South America, and especially in Ecuador, where for over 6 years there was no morphine available for children, causing many people dying with pain because of the very strong restrictions that didn't allow the adequate production or importation of morphine. So I would highly appreciate your comments on this. Thank you.
Thank you. Behind you? No. You wanted to attract attention on her? No? You made a movement. So.
Thank you very much. Camelia Kimileva, I'm the co-director of the Geneva Cities Hub, which is a local organization in Geneva bringing the voice of the cities to the multilateral international diplomacy. But my background is human rights lawyer. So 2 questions. One is institutional, and actually I realized they are related. So the first question is, what is the role of the local authorities into going into the direction of the very progressive direction you have described, decriminalizing, or if not possible, decriminalizing at local level because the laws are different, doing the small margin of maneuver on the local level, probably not to apply the laws harshly, or what is the margin of maneuver of the local authorities? And this commission has worked on this last year, so I would like to hear your reflection. And the second one is not provocative to Ms. Arbour, but I found your explanation extremely sharp, inspiring, as usual, so that's no surprise for this. But you say it's time to discuss, to confront states, you didn't say confront, but it's time to go into the discussion of, in a way, I'm paraphrasing, changing the international public law, which is not human rights law, in the human rights kind. And we know that sometimes there are tensions. So what is your strategy to go at that level? And here comes the relation. If you happen to use also local and regional governments, probably there is more hope for success, because as of now, and probably will confirm or say the contrary, but states are very stuck to apply prohibition. So it's a long run to go into convincing them that they have to become softer. Sorry, I spoke for too long. Thank you.
I think it's for you, Louise.
Well, I can certainly take the last question. I think you've pointed exactly the dilemma that we're facing, which is that I think the best hope for change comes from the bottom. So you see either community groups, municipalities, small entities, ready, willing, but not quite able to take very progressive steps. I gave the example of Canada. It's Vancouver. It's one city on the West Coast that has been launching all these initiatives, taking on the federal government, eventually successfully, but that took 10 years to force the Canadian government to give them the legal authority. In the meantime, though, they were still doing it. It's the problem with that, and they were doing it at considerable personal risk of sanctions against those. It's the same thing with municipalities at the lower level. If you transpose that to the UN system, the same thing. States like Canada, at some point, are in non-compliance with the their international treaty obligation. So to me, the solution is you have to keep doing it, but you have to advocate for change, because you don't want to end up in a system where the rule of law is eroded by non-compliance. But you can't wait. You can't wait 20 years for the entire system to change. So you need to navigate the uncomfortable space of being in non-compliance, but certainly not advocate that this should be, that everybody, I don't know how to put it. Yes, everybody should do it, but as part of an advocacy for global change. So Vancouver is doing it as part of advocating, and very successfully, for an opening up of the space countrywide. And I believe Canada should be doing it with others moving in the same direction, living with the uncomfortable position of being currently, some would argue, in non-compliance, but pushing for that to become the new norm. Because I think to simply say, as was the case for a long time, well, you know, personal possession of cannabis is prohibited, but we'll turn a blind eye. No, either the law is no good, you change the law, but it's a very, very serious erosion of the rule of law if you have a law that you don't apply. That, right? That's not good. But it's a hard field to navigate, but I think that's the only way to do it.
Thank you so much. We have to finish now, but to answer the question on city level or local level, I can assure you that this is one of the activities the Commission is promoting also, networks of cities, and this is also our experience. I mean, when we began in Switzerland to open the first in '86 supervised consumption room in Bern, very quiet city, very conservative, it was considered as illegal. I mean, I had to go to Vienna every year to explain what we were doing. The same for heroin prescription. But this came from the bottom. This came from the cities, this came from the professionals who were at the front really and knew the needs of the people, and not only they knew the needs, they had the trust relation with them so that they could help the people to articulate their own needs, and that is very important. We are working on coalescing and helping coalesce cities. Thank you so much. As I told before, welcome to the aperitif. Was one question not answered?
Access to central medicine.
What was the question which was not answered?
I think, yeah, but maybe your question, because we've worked a lot in Ecuador, and I think that my answer to your question is that we definitely need a multi-sectorial, multidisciplinary approach. In Ecuador, we started doing training for policymakers, because, I mean, one of the main problems that we have, the people working in the field, I mean, many drug commissioners, they have no idea what the difference between drug use, drug dependence, drug addiction, how the brain works, what makes people start using drugs. They don't know, and they are dealing with these problems. And the other thing is multisectoriality, because only drug commissioners cannot dictate, and not only because they cannot dictate, is that they don't understand the complexity. So you need to bring other actors. You need to bring social protection, welfare, education. You need to bring all other areas to really see the problem from different perspectives. I think that Ecuador did great progress when there was somebody in the Ministry of Health fully committed to, and this person died of a heart attack, and all of the work that we were doing all of a sudden collapsed, because oftentimes the work that we do depends on one national champion, as we call them. I suppose in Vancouver was Dr. Gabor Mate, had a lot of influence in that, I don't know. But yeah, multisectoriality would be my answer to your question.
Maybe I'll just add, if you demonize a substance like morphine has been, it starts with being demonized. It definitely makes it a lot harder to access when it's within a framework. It's again, we need to reverse the pyramid completely, fundamentally and conceptually.
Medicine first.
Or
Exactly. Thank you. You are invited to continue with a glass in your hand. Do you think real?
I'm used to that. No, it was very good. It was very good.
Don't be too sensitive.
No, I'm not. No, I'm not.
Thank you.
I'm not.
Just another of
I
the
used to
million
cry.
issues we need to fix.
Thank you.
I used to cry. So I wonder, thank you so much. I really like your, I wonder if I don't
Very diplomatic. The problem is, UN common position. I mean, it's the member states there. But I think the UN, under the common position, the leadership of
your connect. We have the UN not allowing us to write in our document. But then now they are asking for support for injecting us in the US because they are desperate. More than 107,000
Now Biden
people
is using the magic word for the first time in history. And he, a president of the United States, has used harm reduction in his speech. God, I know.
Finally. Do you know that our donor is mostly INS, State Department? We don't get health money for UNODC, which is a shame. And UNODC and WHO, they get nothing. This is what I'm discovering now in this position. I always say, why WHO is not helping us strengthen this joint program to improve prevention, to improve treatment. They don't get a penny. It's mental health unit within the mental health department, and all they do is alcohol and tobacco. That's all they do. Drugs, they do nothing. And we don't receive money also. So who's dealing with the help and creating that system that is very clear? Because this is my question. Who is in poor countries, low and middle income, to create a system that we care for people who the minority will need help. The minority will need help. Should be left alone. Yeah, should be left alone. Totally.
une chose, c'est pourquoi vous croyez que je comprends pas tout à fait pourquoi la Suisse a justement créé cette ouverture à cette recherche, parce que vous savez, ça peut être dans l'entrepreneur que le premier permis pour pourquoi ça se passe comme ça? Voilà, on se souviendra quoi. En tout cas, il faut le laisser. C'est clair, ouais.
Bah, merci beaucoup. Parce que Pascal, il a géré l'écran, un truc comme ça.
Ouais, ça, je vois là, si.
Ah oui, ouais, non, mais bon, c'est bien qu'il a trouvé cette solution.